Actually, you can shut your brains off for this. This is going to be the easiest lecture of the day. It's all low-tech. It's all stuff that you learned on the first day of school when you became interested in eyes. But it is something that you may agree, and I've noticed over and over, that people always say, yeah, I'm not too comfortable with retinoscopy or with refraction and whatnot. And so I'm going to talk to you today just about that and nothing else, about retinoscopy, more as a diagnostic tool, not so much as a method of prescribing glasses or anything like that. That's not what we're trying to do here. But I'm going to make a point to you that if you become pretty skilled with your retinoscope, you'll find it to be one of the most useful tools. So over my career thus far, I've come to respect my retinoscope quite a bit, and that's why I titled this Respect Your Retinoscope. How many people here feel totally comfortable with retinoscopy? All right, 1, 2. All right, so 3, 4. So, good. There's room for learning here. That's good. That would mean that how many people here could, in 3 seconds, if you walk into an exam room, identify the retinoscope? Okay. That's good. That's even better. So we're off to a good start. All right. Can I get light? So what I like most about this test, and it's not the only one that you can say this about, but it's objective, it's easy, and it's quick, and it's accurate. And those adjectives are only true if you practice a lot and you become good at it. It's quick because once you get good at it, it's a lot more accurate than any autorefractor, and it's a lot quicker than any autorefractor, believe it or not. Okay? Objective is probably the greatest power. Sometimes, and this doesn't just apply to kids, but even elderly individuals, you don't know exactly if you're getting a truthful answer from them. What's better, number 1 or number 2? What looks better, this lens or that lens? So if you can trust your objective measures and go with that, that saves you a bunch of time. There's a lot of questions that we have to ask when we are doing something like this, and they're plastered all over the screen here. Not unlike any other test you might have to do. So it's not easy. So, I'm not here to say, oh, this is easy, and if you can't do it, there's something wrong with you. No, this is something that when I graduated from optometry school, and they were lecturing me about diabetes and diabetic syringes, I was thinking in my head, boy, I'm about to graduate, and I still don't feel comfortable doing retinoscopy. It's a tough thing, and even well into my career, every year I felt the more I did it, the better I got at it. So you do have to do a lot of it. And you always have to ask a lot of questions. All these things are important. So we'll start with the basics, with motion, against motion. You remember those terms. And we can easily remember or memorize what those things mean, but if you understand why they mean what they mean, this might start making even more sense to you. So here you have a hyperopic eye. Light is entering the eye, and it's focused beyond the retina. That's the hyperopic situation. So if you take your retinoscope, this is what it looks like for those who don't know, and you pass your streak across the pupil, you want to see what the light is doing that hits the retina and bounces back at you. That's the reflex, right? That's the red reflex. And so does it go with the motion of the beam, or does it go against the motion of the beam? In the hyperopic situation, it goes with the motion of the beam. Why is that? Because all of these rays are focused over here, and you're getting the reflection from over here. These rays come out the same way they went in. The opposite, this will make more sense. I probably should have shown this eye first, because what happens in the myopic situation is the light is focusing before the retina. This ray crosses over. And so if you're passing that ray in one direction, you're going to get a reflection in the opposite direction. So that's why you get against motion. And you can say that about every single light ray that enters the eye. So that's why we get with motion. And how do we correct for that? We place a plus-powered lens of the appropriate power, whatever that may be. I didn't show it on here, but if this is the right power, +3, +4, +1, whatever it is, it brings this focal point right to where it should be on the retina, and that's the correct prescription for that patient. So we have the myopic situation I already talked about. We have the light rays crossing over at this point, and this is why we get an against motion when we are looking at the reflex coming from the surface of the retina. And again, we'll use a myopic lens or a biconcave lens to diverge rays. It's not happening in this picture, but you would want to diverge just enough so that these rays ended up focusing perfectly over here. You move that focal point to that position on the retina. Working distance, that's another big, scary word. You have to think about it, because your light does not come in parallel from an infinite distance. It comes from a point source. It comes from your retinoscope, and it diverges towards the patient's eye. And your patient's eye, and your patient has to accommodate for that. So you have to factor that in, that you're not presenting parallel rays to the eye. You're presenting divergent rays to the eye. And that's why you have to factor in your working distance. When I worked with kids, working distances were all over the place. A lot of times I was this close to the kid just to get a right reflex. I was always pulling out the measuring tape. With adults, it's a little more standard. I kind of have already measured 66 centimeters, whatever it is, and you can convert that to diopters, 1 over whatever your working distance is in centimeters is the dioptric power that you have to subtract out of your answer when you're determining the prescription. Where should the patient look? It matters. If they're not dilated and they're accommodating because they're younger or at any age, you have to be aware of that. So if I have a younger individual that's not dilated or cyclopleged, and they're looking at my target, that's going to change the refraction because they're accommodating. So I actually want a non-dilated, non-cyclopleged eye to look at a distance target while I come in close from my working distance. If they are cyclopleged, like we typically do on all of our kids and all of our patients, on all of our adults, then they can look right at your light, which is a lot easier because they can't accommodate, and plus you're looking at them dead on. So that's going to be your most accurate answer. So to do accurate retinoscopy consistently and efficiently, you should always do it on a cyclopleged eye. So don't forget to subtract your working distance in every situation, and this happens at the end. By the way, interrupt me along the way if there's any questions. So again, objective, quick, easy, accurate, unobstructed, unintimidating. You take that 4-opter, you put it in front of somebody, you know what the heck's going on here. Number 1 or number 2, number 3 or number 4. I can't tolerate it. I worked with kids for 13 years, probably used a 4-opter 5 times in all of that time. I don't have time for that thing. So again, learning to use this is extremely useful. And diagnostics, since I've come here, I'm not handing out prescriptions all the time. I'm not reaching for my retinoscope all the time. But I hope I have enough time in this lecture to show you that a bunch of examples in which retinoscopy really helped me in my examination, okay, as a diagnostic measure. I'm going to cheat, and I'm going to use a YouTube video which I came upon while I was preparing this. And Tim Root is the name of this physician that has put together a whole bunch of different episodes on YouTube. So I would, if you're interested, copy it down, and you could probably learn a lot from his other lectures. So, I have it up over here. Sorry.
Loose lens retina. This is one of the harder skills to learn in ophthalmology.
Okay, I'm going to just show you bits and pieces. This is a repeat of what I talked about already. It's more interesting, but
Well, light coming into the eye doesn't focus right. It actually focuses behind the eye. And if you move your retinoscope up and down, the light moves up and down, and where it strikes the back of the retina, it also moves up and down in synchrony with you. When it comes back at you and you look at it, you're seeing a with reflex because the reflection is moving the same direction you're moving your instrument. If we hold a lens in front of it, not quite strong enough yet, we don't have the correct prescription, you still see a with reflection. The light going up and down, the reflection on the back of that retina is also moving up and down. We add a stronger lens, the correct prescription in this case, and you hit that retina perfectly, the light bounces back at you in a nice bright reflex. You neutralize the reflex. This is the correct prescription for this eye. Now, if we decide to use too powerful lens, we put a very strong plus lens in front of that eye, the light actually focuses in the middle of the eye. And as you move your light, you almost get a seesaw reaction. And a reflection off the cornea, off the retina, is actually in the opposite direction you're moving. We call this the against direction. So with versus against. Until we can figure this out. There are 3 steps to retinoscopy. The first step is you have to start with motion. If you have an eye that has against motion right at the beginning, you're going to become confused. You have to have it. The second step, you add power, like we just did, until you neutralize the reflex. And finally, at the very end, you subtract the working distance. And we'll go over that in a second. So this is a cardboard cutout I created just for this lecture, to try to simulate what this looks like. I could have animated everything for your last little animation, but it was going to take forever. So
there we go. I just wanted to say, he said always start with motion. I think a better way of saying that is, and this especially applies when you're dealing with astigmatism, is you always want to identify the meridian that is the least plus or the most minus. If you work in ophthalmology, you always want to write things in plus cylinders, so you're working from least plus or most minus, you're adding plus to get to the other meridian. And so that's where it comes from when he says you don't want against motion. You'll see that over and over again.
Basically, I use South Park techniques, cardboard cutout, and we're going to see if we can use this to figure it out. So once again, we started with width, the reflection is going with us. We add power to the system, still not strong enough. I'm doing it in a couple of different axes, and I'll explain that later, but for now, we're just looking for spherical problems. Let's try it +3. Our beam's getting, and only now can we start adding plus. So we'll -3, it's a dot or stronger. And it looks like we've hit probably the perfect prescription here. Let's check the other axis, make sure it's both ways. This patient doesn't have too much astigmatism. Nope. All right, set your lens aside or leave it out, because if you put it back, you'll forget, you'll do the math in your head, you'll mess it up. And so what we have here is a -3 sphere, got the sign of focus. You correct for your working distance, so it's a -150, and you end up with a -450 spherical power.
Is a -3. -3 plus 450, axis 90. So maybe I should have shown that after the next video, but that's why there's repetition through this lecture, okay? And this is another way of demonstrating it. I also like to use skioscopy bars, or what you call lens racks, which has a nice series of lenses all in one handy-dandy bar, so you don't have to keep picking up different loose lenses. You could think about this as a lens rack, or just a scale. So in the same situation, here's the minus 150, and here's, let's just say, the plus 3. We started here, and then we had to add power until we got to here. The difference between a plus 3 and a minus 150 is the span of diopters here, which is 450, okay? And then a minus 150, remember the last step, subtract out your working distance, plus another minus 150, ends up being a minus 3. So minus 3 plus 150, that's 90. Okay, one more video.
To neutralize the reflex. And at the very
Don't tell me that.
end, subtract the working distance to go with your final prescription. So what about astigmatism? This has been pretty easy.
Is the, I can't remember his name. Ron Aaron?
Here a minute ago.
By his office. Call it.
Well,
Yeah, it's easy. Right. Just practice it.
okay. I picked up my head, but I think I just wait for Ron. Any questions? No?
So far, it was this easy. Anyone can do it. It's not an issue.
How dare you leave? I just...
Start with width. You have to start with width. All right, so we've got width motion
Right.
in both directions. Let's start adding power. Still have width, so not yet that direction. Let's try this direction now. Still need more. Let's add some more power. Try plus 2. We're getting close. Our beam is getting a little wider. We're nowhere near this direction though, so let's keep adding power until we neutralize these things one at a time. So let's try this way. No, still need a lot more this way. However, this way, we've got it.
So he
This is the
found
right
his
prescription.
first
Let's
meridian.
set
Now
this
he's
lens
going to set that
Set it
aside, he's
aside,
going to
or go
flip his
15.
beam, and he's going to
Set it
keep
aside.
going.
Keep adding power, and let's go back to the other direction until we fix that too. Still have width, not quite there yet. Let's try this plus 5 lens. Perfect. Now we have the right power for that meridian. Set the lenses aside, and now you can start thinking about the numbers and writing these things down. So this prescription is what? It's a plus 3, plus 2. What's the difference between them? And the axis, we can just look at where our light beam is oriented right now. It's going sort of horizontal. We know the axis is at 180. So the answer is a plus 3.
The other nice thing about working in plus cylinder is your axis ends up being the axis that you ended up on when you finished. So he had his axis this way, he found his +3, he flipped it this way, he kept going, then he found at +5, that was the other focal point, and now he has that axis 180, he doesn't have to flip anything, it's just, because he did it in plus cylinder, it's going to be axis 180. So what's going to be his answer here? What's his final prescription? Right, plus 150. So the difference between the two is 2, so there's 2 diopters of astigmatism, axis 180, and then a 3 plus a minus 150, or a minus 150 is a plus 150. So plus 150 plus 2, axis 180.
Plus 2 at 180. Write it down. Don't do the math in your head, just write that down. And at the very end, subtract your working distance, and our final prescription is a plus 150 plus 2 at 180. Not too bad. Let's do another example. This is good practice. All right, we've got against motion. We can't start with against motion. You're going to get confused. So what do we have to do? We need to back off, because you've got to start with width before you can figure these things out. So let's put a minus 2 up. Good. We've got with motion that way. We still have against. This is no good. You cannot have against motion at the beginning. You'll get confused. So let's throw a minus 4. If I got to go to minus 10, so be it. Now we have with motion in that direction. We have with motion in this direction. Now we can continue and add power until we neutralize it. So let's add a diopter. Minus 3. We still have width. Not quite there yet. Let's check the other direction. We've got it. We've got it this direction. Let's set this lens aside. Set it aside. You'll get confused. Just set it aside. Get a stronger lens and keep going the other direction. So we're going to add a little power. No, you still need a lot more, it looks like. Not surprising. Okay, let's add some more power.
So he's adding more plus, right? He's going from minus 3,
I
minus 2,
think we
minus
may
1.
have it. This might be it. Do I try it more? Do I dare? Let's try Plano. No, Plano's too strong. The minus 1 was the right one. So put these lenses aside. Put them aside. If you don't put them aside, you'll get confused. Now you can write it down. This is a minus 3. The difference is a plus 2. And the axis is at 90. You write this down. Minus 3 plus 2 at 90. Then you do the math. Subtract your working distance, and the final answer is minus 450. Plus 2 at 90. Not too bad. All right, we're going to do this one more time. We have against motion here. It's no good. Can't start with against. You got to have width. You can't continue. No.
I don't know what happened. That's what you're going.
Still a problem. It's okay this direction. It doesn't matter. You got to start with width in every direction. Otherwise, so let's throw a minus 4. All right, we definitely have width this, so this is good. Let's try the other axis. Make sure it's still good. Now we have width in all meridians. We can continue in step 2, which is where we add power to neutralize reflex. Try minus 3. I think we've got it. We've got it this direction. So let's set this lens aside before we get confused. And now we'll continue to add power and work on the other direction. So we'll try a minus 2. No, not quite there yet. We're getting closer though. I think we're getting closer. Let's try minus 1. I think we've got it. I think this is it. Set it aside. Then write things down. This is a minus 3 plus 2. That's the difference between them. The axis is at 180. Write that down. Minus 3 plus 2 at 180. Then, and only then, do you subtract your working distance from that sphere power, and your final answer is a minus 450 plus 2. All right, we're going to do this one more time. And then we'll...
Okay, and then one last bit here.
board, but we're doing everything in our head. So here we go. Start with width. Good that direction. Good that direction. Okay. Let's add some power. Plus 1. not quite there yet.
Okay, it's going faster.
Not quite there yet. Let's add some more power. Plus 2, okay. 150. Okay, we're getting there. I think we've got it. I think we've got it. Let's put this lens aside and continue on in the other direction. Try plus 2. No, not there yet. Plus 3. I think we got it. This is the prescription. Now if we do this in our head, this is a, sorry, no, too far. I'm glad I set that first lens aside, otherwise I would have lost it and forgotten. So, what's our prescription? It's a plus 150, plus 150 at 180. In our head, we do the subtraction and it comes out to being a Plano plus 150 at 180. Let's see if we are correct. Plano plus 150 at 180. That's how we do it. Let's do a harder one. All right, well, I think we got it right off the bat. Good, so that's a Plano that direction. We still need some more power that way. So let's add plus 1. It's not quite there yet. Let's add another one. Get closer. The reflection's getting larger. Let's add another one. I think we got it. Perfect. Am I getting greedy? I am getting greedy. Let's try it. No, we've gone too far. So let's get that plus 3 lens out. Lay it on the counter before I forget. And our answer is it's a Plano plus 3 at 90. And we do the math in our head, and the final answer is a minus 150 plus 3 at 90. Let's see if we got it. Perfect. Minus 150 and 3.
Does everybody get that one? Because as soon as he just didn't even pull the lens up, he just had his scope and it was like neutral right there. That was Plano, right? So he takes his Plano, subtracts his working distance, he gets a minus 150. And then the astigmatism is the difference with the next meridian. Okay, we're going to just finish up here.
One last one. This is our last one, I promise. It's a funny angle. Got to change. All right, good. We go with motion this direction. That's fine. We've got against. No, that's no good. We can't have against. You got to start with, or you're going to get confused. Let's throw minus 2. Perfect. We've got with motion that way. We've got with motion that way. We can continue. Let's add some more power to the system. Not quite there yet. This direction. We've got it this way. Let's set our lens aside. We're going to get confused and keep going the other way. Playing it up. Not quite there yet. Plus 1. They've got a fair amount of astigmatism. Not quite there yet. Plus 2, let's try it. No. This is a high astigmatism. Let's try another one. Okay, we're getting close. I can tell. Let's add another one. Boom, we got it. So, set our lenses aside. Do the math in our head. This is a minus 1 plus 5 total. And the axis is about 45 degrees. You do the math in your head, and it ends up being a minus 250 plus 5 with an axis of 45. That's our final answer. Minus 250 plus 5 at 45. I have put this sample in your notes so that you can kind of figure out how this works. The same photo from this last one is in there, so it should make sense. But in summary, there are 3 steps to retinoscopy. You have to start with width, then you can add power to neutralize the reflection. You may have to do it in different meridians and set your lenses aside. And the last step is you subtract your working distance.
Questions? That makes sense? Go ahead.
How do they find the astigmatism if it's not, I don't know, how do you do that? Like, if it's at a 37-degree angle, how are you supposed to
Good
know?
question. So, as you saw in that one, it was kind of on an angle like this. There's many ways to do it. Obviously, if it's perfect, it's 90. If it's perfect like this, it's 180. If you have a 4-opter in the room, a lot of times what I would do is if I would just keep the axis as I see it on my patient, so rotated like this, and I'll go to my 4-opter and just sort of line it up on the scale and read it right off my 4-opter. Make sure your 4-opter is level, you know. There's many different tricks you can do. Yeah. So again, for prescription purposes in adults, this might give you your starting point that you then shuffle into your 4-opter and very quickly just refine the axis. You could do that too. In kids, I didn't worry too much if it was axis 45 or axis 47 because they walked in minus 10 plus 7. So, you know, the fact that they were just getting glasses was a great start. But you can be as picky as you want to be, but yeah, you usually will defer to your 4-opter, or there's also loose lenses, loose trial frames that have scales on them too that you can pick off of. Yeah. Any other questions? That's a good question. And then, the scissoring. If you guys ever see the scissoring, that's always confusing to people. It's not really an against motion. It's a reflex that you're like, I don't know if that's going with, I don't know if it's going against. It looks kind of neutral. I don't know what's going on. That just has to do with the fact that your cornea is not a perfect curve, right? It kind of goes like this, and it kind of flattens out to the edges. And so you might get different reflexes from different parts of the cornea. You really need to just focus in on the very center of center reflexes. So just focus in on the most robust reflex coming from the very middle. And again, just a lot of practice. It just depends on what level of keratoconus. If there's scarring, I'm glad you brought that example up. With keratoconus, if there's scarring, you're not going to get an autorefraction reading. If there's even minimal scarring, you'll get a bunch of errors or you'll get a bunch of crazy answers. That's when you pull this out. And that, if you've done this a lot on normal healthy eyes, this will come in handy. You can actually, a lot of times, obviously if it's dense scarring, you can't do too much even with this. But if you're going to get anything, it's going to be with this. And at least you can say, okay, they're about a -10. They have about 6 diopters of cylinder. Seems to be an irregular axis. Your autorefractor won't even give you that, So that's why this can be a very useful tool. So when I dealt with keratoconics, this is all I used. And I wouldn't even trust an autorefraction if it came back that it was accurate. I would always double check it with this. Good question. Okay, back to mine. Yeah, let me do that. Okay, we have enough time for just a few examples, and then okay. So again, I'm going to give you some cases. These are real cases from the day I started here until last week. I just kind of kept track of some that I thought would be instructive in ways in which I've used retinoscopy to sort of help me diagnose things. The first patient is a 58-year-old with declining vision in the right eye. Said to me that it looks like there's Vaseline over my vision. So check one, make sure there's no Vaseline in the eye, right? There was not, okay? Acuity, 20/80, pinholes to 20/50. Okay, so we know what that means. We know that maybe if we put this person in glasses, they could at least get 20/50 vision. Pinhole is good, it's great if you pinhole to 20/20. Problem solved. At least refractively they're capable of that. But 20/50, then sometimes you're like, well, did they even understand the test? Were they trying hard? Did they even get it? Clearly some people don't get it. They struggle with it. So if you get that feeling, it's nice to have this. Okay, and I guess with this patient, I had that feeling because I really didn't see anything else going on. So before I send this patient for this and that referral, I want to make sure. So I pulled out my retinoscope. These are the glasses she was wearing, -3s with some astigmatism. So I had her put those on, and I did retinoscopy over her glasses with loose lenses. I could tell right away that there was more minus to be had there over her right eye. So I ended up with a -350 plus my working distance. That's a shift of -5 over top of her -3. That gave her 20/25. Now we can talk about why there's a big shift, but the point is, now I know I'm dealing with an eye that doesn't have any vision loss. There's a big refractive change for some reason, but I've really zeroed in on a different problem, okay? Case 2, a 39-year-old with blurry vision for 4 to 5 months. Recent facial numbness and headache, prompting this person to go to the emergency room. They did an MRI. They determined that she had lesions in her brain consistent with MS. Go see Cincinnati Eye Institute. Comes to see us, 20/20, 20/40. I'm thinking MS, optic neuritis. Let's look at the optic nerve. Let's dilate. What's going on here? I look at everything, looks healthy. That doesn't mean she might not have some other process going on deeper into the brain, but I felt compelled to pull up my retinoscope. And so she's a -1 in that eye. And so at least now I know that she's capable of 20/20 and that she does not have any vision loss at this point. Okay? Even if you do that and you scope really quick and you're like, okay, it's about a -1, so you put a -1 up there and she reads 20/20, it's not that you're prescribing glasses. You're giving that information to the doctor you're working with. That's going to be super valuable. Just that right there. Okay? A 16-year-old with blurry red, painful right eye. She went to the ER and they suspected an allergic reaction to almonds. Okay? You ever hear that? Be very suspicious. Okay? Because it sounded suspicious to me. She was given Benadryl and a steroid shot. Basically, she had almonds, which she had had her whole life, and all of a sudden her eyes were red and swollen, and so just didn't add up. Healthy young girl. Look at her entering acuities, 2400, pinholes to 2080, never had glasses, never had contacts. What's going on, right? This was my colleague, actually. This was day 1, and they documented 3+ ptosis of the upper lid. That was it. They came back early the next day, and they ended up in my chair. And now vision's even worse. Hand motion, 2100 even in the other eye. And I did document the upper lid swelling. I palpated her here. She was tender. Right away, you know she's got an infection. She's got a viral. She's got a pink eye. So look at this. Day 1, 2400. Day 2, even worse. Pull out my scope, -50. Put it up in front of her. She reads 20/30. I'm done. Go home. You're now allergic to almonds. Get out of here. Right? So again, very easy, very quick, very diagnostic. If your gut's telling you something's off here, it can be very, very useful. Okay. Let's go up to something more interesting. 45-year-old with blurry vision in the right eye for 2 to 3 weeks. He was from out of town, from Boston. Had this issue, went to a local emergency room, got a CT scan, was told it was normal. They wanted to refer to Dr. Golnick, but Dr. Golnick said, no way, I'm not seeing this patient. Go see Dan in urgents. I only say that because I just saw him walk in. All right, that's not what was said. Acuity was 20/50, pinhole to 20/25. And so now you know, even if you stop right there, because pinhole he did so good, you could probably estimate this is refractive, it could be done. But of course, I pulled out my retinoscope, and this is what he was wearing in that right eye. Now, he had his prescription with him from his optometrist, so we converted it over. Then I did retinoscopy, and I got 20/25 with this. So I was able to tell him, okay, your prescription's off. The biggest problem here is your astigmatism is right at 2 diopters, but you're 90 degrees off. So, that explains it right there. Plus, I was finding more minus. I'm getting a -50, not a +1/4. So at least I could say, okay, no more CT scans, no more MRIs. As soon as you get back to Boston, go back to your doctor. Maybe your lens fell out, and you put it in backwards, I don't know, but you're okay, right? And one last case, 27-year-old with redness and pain and tearing in the right eye more than the left eye for a few days, complaining of blur, and he's hand motion in his right eye, 20/25 in his other eye. So first question I asked him, obviously, is, have you always had trouble seeing out of that eye? And he gave me the right answer. He said, yeah, I've always had major vision issues in that eye. So I pulled out my retinoscope, it was a -10/50. What I saw there was I saw nothing, darkness, okay? So that tells you grab a big lens. Don't grab a -50, grab a -8 or something. I think that's what I grabbed. minus 9. I saw a nice bright reflex after that. My working distance, minus 1050. Still hand motion because he's been that prescription his whole life, very amblyopic. But now I know it's a red eye, it's a pink eye, it's a viral, it has nothing to do with his vision, and, you know, we can move on. So, with that said, I will just say that this slide was really for kids, but I think now with working with adults, it still applies. People, 3 main reasons why you can't always trust subjective answers from your patient and why objective measures like retinoscopy are great. Because people are adaptable. They get used to things that have changed so quickly that they can now tell which change was better. So if you start saying, what's better, number 1 or number 2, number 1 or number 2, you've been behind the foropter, it gets confusing, you start adapting, you know, what's going on. If you can eliminate that, that's good. People are impressionable. They pick up on cues, hints, they start telling you what they think they want to hear, that you want to hear them say. So they get intimidated too, okay? And people can't control their accommodation, especially if they're not dilated cycloplegic, especially if on the younger side, that may be playing a big role. So I like objective measures, and very handy-dandy tool. So practice on each other, practice on healthy eyes. That's the best way of learning, and then keep doing it if you're interested, and you'll get better. So thanks for your attention. If there's any questions, otherwise I think, yes. Right. Yeah, it's a good question. You've got to use this during the four-opter exam. So if you notice, your optometrist will sit there. They have all their lenses dialed in there, and they'll use it initially. So it is part of the examination. It's a matter of preference. It's a matter of training. It's a matter of patient population, but if you move that four-opter out of the way, you can still use this in a different manner, and it can be just as accurate. The four-opter, I won't say it allows you to cheat, but it is a mechanism that really allows you to use the subjective responses from the patient to come up with the final answer. Whereas this is extremely objective, so you really have to know this well to trust it. So, you know, I didn't feel good about this when I started using it, but after using it over and over and over and over, then I was like, never mind the four-opter, I'm going with this. So it's just a matter of training and experience. Yeah.
Any other questions?
Thanks so much. Yeah.